Girish.
Hey.
Got to cut you off. Hi. Good afternoon, everyone. So we will get started with today's endocrine grand rounds, and we are very happy to have Dr. Harpal Sandum, who is here in the ophthalmology department as the assistant professor. He had his undergraduate training in medical school at Harvard, and subsequently did his residency also at the Massachusetts Eye and Ear Infirmary and fellowship in Retina in Philadelphia. So he has been here since 2016. His interests have been focused on retinal disease. He has had many investigator-initiated grants and other studies and has 28 peer-reviewed publications. He is going to talk to us today about diabetic retinopathy, current treatments and unmet needs. And as diabetologists, we are very keen to learn about it, and I'll have him take over.
Thank you. Thank you very much, Dr. Moksha for that introduction. So let's get started because there's a lot of ground to cover here. I'm going to try to look at the camera, though I will occasionally look to my left because we have a live audience as well. Okay. Oh, how do I advance the slide here? Okay, I got it. My disclosures are here. None of them are relevant to this talk. And of course, for being a site PI for an NIH trial, I don't receive anything, as all the clinician investigators here probably know. But there they are, not relevant. I am going to very briefly at the end talk about artificial intelligence applied to fundus images on those fundus cameras that some of you probably know about. But I do not work in that area. I've done work with optical coherence tomography, so no overlap. So our learning objectives. Briefly review the staging and complications of diabetic retinopathy, review the current treatments of diabetic macular edema, learn the options for treating proliferative diabetic retinopathy, and understand the pros and cons of each, because there's now basically two approaches when there used to only be one. And then finally, understand the unmet therapeutic and public health needs in diabetic retinopathy. So I won't belabor any of this. This audience probably knows these sorts of figures better than I do. There's at least 23 million diagnosed diabetics in the US, probably more than that, many of whom are going around undiagnosed, 7 million or more. And of course, diabetic retinopathy is one of the principal microvascular complications of diabetes. And just the prevalence in all comers with type 1 diabetes and type 2 diabetes is very high. So any diabetic retinopathy in type 1 diabetics is 70% versus about half of type 2 diabetics. Proliferative diabetic retinopathy, which is the advanced form that carries a high risk of vision loss if untreated, almost a quarter of type 1 diabetics, 6% of type 2 diabetics, and then macular edema, which we'll talk about, also significant but lower. Diabetic macular edema is the leading cause of vision loss, although it's generally reversible in diabetics. Proliferative diabetic retinopathy, or PDR, you're going to hear me use those two acronyms a lot. DME for diabetic macular edema. This is the relatively new term that has replaced the old term, clinically significant macular edema, which some of you probably remember, CSME. And then PDR, the advanced form with proliferation of new blood vessels. And this disease dominates ophthalmology. Diabetic retinopathy and glaucoma are really the two largest public health problems in all of ophthalmology. Age-related macular degeneration would be a distant third in the developed world in the United States. Let's just quickly review the anatomy of the eye. Just the basics are really all that are necessary for this talk. Of course, we have anterior and posterior. So light enters through the cornea, which is transparent at the front of the eye. It passes through the lens. This is the part of the eye that when it opacifies with time or other causes, such as diabetes, turns into a cataract, goes through the vitreous and is ultimately focused here on the retina, okay? And the retina extends almost like an umbrella around the posterior half of the eye, okay? And then here's what I see on the right. I basically see something like this when I examine our patients with my various lenses and indirect ophthalmoscope. So this is now looking at the center of the retina. Here's the optic nerve, just a little bit off to the side. These are the normal blood vessels. And the area bounded by the optic nerve, the superior arcade, the inferior arcade, and then going out about 6 disc diameters temporally is what we call the macula. And this is the most visually significant portion of the entire retina. This is where we get our sharp central vision from. So pathology in this area is very visually significant. And that's where we get the term diabetic macular edema from, of course. All right, let's just quickly go through the stages. This is probably review. So what we hope all our diabetic patients will have is DM without DR, so diabetes without any retinopathy. Of course, most will eventually progress to non-proliferative diabetic retinopathy, or what used to be called background retinopathy. And we generally grade that as mild, moderate, or severe. You'll see other more sophisticated grading scales in clinical trials, but they're really not clinically that important. And then, if patients really advance, they're not well controlled, or for whatever other reasons, there are some genetic predispositions too, they can start to grow new blood vessels in the retina driven by ischemia, and that, by definition, is proliferative diabetic retinopathy because new blood vessels are proliferating. And we have a further 2 gradings of this, non-high risk versus high risk. That's for us ophthalmologists, but it really has to do with how much neovascularization we're seeing in the retina because you have different risk of vision loss with those different levels. So those are the stages, but then there are structural complications. So when we talk about someone with diabetic retinopathy, we do both this, so we come up with what their diagnosis is, what their stage is, but then we also list separately if they have any structural complications. And these are the 3 principal structural complications. So diabetic macular edema, or DME, vitreous hemorrhage, so blood spilling, let me go back to that photo, blood spilling into this area, the vitreous cavity. And tractional retinal detachment. So this is a special form of retinal detachment that mostly diabetics get. It's not the run-of-the-mill kind that's caused by a tear in the retina that usually requires surgery very quickly. I'll talk a little bit more about this when I show you some photographs, but it's a complication of massive proliferation of blood vessels in the retina that ultimately undergo an angiofibrotic switch. So they switch to fibrosis and slowly detach the retina. And these structural complications are the principal causes of vision loss in diabetes. All right, so a few images here. So here's a normal retina. This is what we hope to see in all our patients. Here's a patient with mild NPDR. So you can see they have these little red spots. These are microaneurysms in the retina. And all it takes is one microaneurysm for us to diagnose a diabetic with mild NPDR, although we might call it trace. This is moderate, so now you have more MAs. MAs are microaneurysms, as well as dot or blot hemorrhages. In this case, this patient also has macular edema, and you can tell this because they have basically lipid exudates in the macula. So this is caused by edema that leaks from the capillaries into the macula, and then as the edema resolves, lipid that's spilled out into the retina takes a much, much longer time to resorb. So we see that. These are cotton wool spots. And what these are focal little areas of ischemia to the superficial layer of the retina, what's called the nerve fiber layer, and they look like cotton wool, hence the term. And severe NPDR, this is really just a matter of degree from moderate, although they can also get some intraretinal microvascular abnormalities that can qualify for severe NPDR. Now this is PDR, okay? This is a particularly dramatic case, and I picked it so that it would be more apparent than neovascularization. This would be highly advanced. We try to catch patients much sooner than this, but this is all abnormal. This is massive proliferation of new blood vessels around the optic nerve, the front of the optic nerve, which we call the disc. So this is neovascularization of the disc, NVD. Patient also has massive neovascularization elsewhere. So you see that here. This patient is very high risk for vision loss. So without treatment, a patient who has high risk proliferative diabetic retinopathy has an 80% risk of becoming legally blind at 5 years. Extremely important to treat this aggressively. All right, so let's go through the structural complications. One, macular edema, our most common one. So here's macular edema. This is often what you'll see. You'll see these lipid exudates in the retina, okay, in the center of the retina, which is the macula, of course. In the old days, before we had optical coherence tomography, or OCT, we would diagnose this condition purely based on our examinations. We would look for thickening here, which can be very subtle, but we would really look for these lipid exudates close to the center of the macula. And so we used to call it clinically significant macular edema, CSME. But now we've stopped using that term because we have this technology on the right here. This is an OCT of the macula. It's really revolutionized what we've been able to do in ophthalmology and retina in particular. This technology has existed for about 10 or 12 years at this resolution, and it allows us to image the macula at a resolution of about 5 microns, which is incredible. The normal thickness is about 250 to 300 microns, so that means from here to here. This patient's very edematous, so these black circular or ovoid spaces are spaces of fluid or edema in the macula. So we're diagnosing macular edema now from the OCT and not so much from what we see on exam. So that's why we've switched to this term DME, diabetic macular edema, because we can often see degrees of thickening that we never would have seen before with our examination techniques. So this patient's very edematous, and that will decrease vision. Macular edema blurs vision. It also causes metamorphopsia. So if your patients ever complain, not just that it's blurred, but that things that should be straight are wonky or distorted, that's macular edema. Get them over to us, please. And again, for comparison, here's a normal retina and a normal OCT. Dramatic difference, right? So this distance from here, so the deepest portion of the retina to here, the more superficial portion of the central macula, which is called the fovea, should be about 250 to 300 microns. All right, structural complication number 2, vitreous hemorrhage. So this is caused by NV, so neovascularization, that has now started to bleed. So these pathologic blood vessels are extremely harmful to the eye. They will eventually either bleed or scar, causing either vitreous hemorrhage or tractional retinal detachment, respectively. And all it takes is a tiny amount of blood in the vitreous to just ruin vision. It's reversible, thankfully, but just imagine like dropping a little bit of milk into a glass of water, and the way it clouds up, it's like that. So all it takes is a little bit for patients to dramatically lose vision. Okay, and this patient obviously has a significant amount of vitreous hemorrhage. They could have a profound decrease in vision. And here's the tractional retinal detachment, or TRD, that I was talking about. So what's happened is there's been neovascularization of the optic disc, neovascularization around the arcades, and this angiofibrotic switch has occurred. So it switched from being predominantly vascular tissue to being fibrous tissue. And what that does is it forms on top of the retina, and it tenses up the retina, just like pinching your skin, okay, and lifting it up. And it happens slowly. That's why we don't do anything about it when we first see it. We just try to treat patients medically. But eventually, if it's severe enough, it will detach the retina, and it requires surgery. And this is very severe because these patients, first of all, the surgeries are technically difficult, but still usually successful. But even with anatomic success, often the visual outcomes are poor because the ischemia to the macula has been so profound that vision does not return as much as we would like, although it can. And I've put a picture of the normal macula adjacent to the TRD so you can compare. I mean, it looks like a war zone, right, the TRD. And it is a disastrous complication for someone to get a TRD involving the macula. This is a major failure of eye care and sometimes, unfortunately, public health care because patients will present to us like this. All right, other manifestations of diabetes mellitus in the eye. I'm just going to go through these very quickly, more for the medical students and trainees. It's not the focus of this talk, but diabetes can affect the eye in so many ways, in fact, the body in so many ways. It's incredible, as I'm sure the audience knows better than I. True diabetic cataract. This is something we rarely see anymore, but sometimes with really profound and rapid changes in serum glucose, the osmotic changes in the lens can lead to a rapid whitening and opacification of the lens. So here's the lens here behind the pupil. We've obviously dilated the pupil pharmacologically, which is what we do in the retina clinic, and it looks white. And that's because of these osmotic changes. Now, this is actually reversible, believe it or not. It's one of the few types of cataracts that can actually resolve on its own without surgery. But this is very rare today. Diabetics just tend to get regular cataracts at an earlier age. So instead of getting them in their 60s or 70s to a visually significant degree, they might get them in their 50s. They can get them even earlier than that, in their 40s too. Sudden changes in the refraction of the lens. I've highlighted this because this is something that I'm sure all of you have heard from your diabetic patients. They come in, they say they don't feel right, and their vision's blurred. It's different from what it usually is. Their glasses aren't working. And it's not that they've suddenly developed macular edema or PDR. It's that they have high serum glucose. And again, it's causing these osmotic changes. And no, it's not causing cataract, but it will cause the lens to swell. And once the lens swells, that changes how it refracts light. So light will no longer be focused on the retina, okay, even with their glasses. Their glasses are designed for a lens that's normal. You know, that's when they were refracted, when they saw an optometrist or an ophthalmologist. And this will usually resolve. Of course, you get their blood sugars under control. It'll resolve, although it can take some time. It can take a month or more before it completely returns. Extraocular muscle palsies, cranial nerve 4, and in particular cranial nerve 6 palsies. So this patient here has a third nerve palsy. So remember, 3, 4, and 6 are the ones that control the extraocular muscles. This patient's eye is down and out, and he has ptosis because he has a palsy of the third nerve. Very common from basically just a microvascular, it's not a stroke, but it's a microvascular abnormality in the tiny blood vessels that feed these nerves. And these will usually improve on their own, though it takes time, and of course they need to control their blood pressure and blood sugar. Sixth nerve is probably the most common. So in that case, right, that's the one that causes abduction, moves the eye out. So when they lose that, their eyes turn in and they get double vision. This patient will also have double vision if he can get his eyelid up. Iris changes. Okay, this is extremely bad if this happens. So this is neovascularization that's become so severe, it's not the retina that's become neovascularized. That's already happened. Now it's progressed anteriorly towards the iris, so the colored part of our eye. This is extremely bad because the trabecular meshwork, the drain in the eye, the proverbial drain that allows the aqueous fluid to leave the eye and maintain a normal eye pressure, is right next to the iris. So these blood vessels will eventually invade the angle, which is where the trabecular meshwork is. The angle is the angle between the iris and the cornea. And it can cause a severe, rapid form of glaucoma called neovascular glaucoma. Extremely dangerous and painful. Requires emergency treatment. And optic neuropathy. Patients will get something called diabetic papillopathy, which can cause the disc to swell. It's basically a non-arteritic, non-vasculitic ischemic optic neuropathy, though they usually do well, again, just with time, blood pressure control, glucose control. All right, let's get back to diabetic retinopathy. I was here 3 years ago, and I don't remember who it was, but one of the attendings asked me, I was going on about clinical trials, and I was saying, oh, there's this many lines of improvement, and they went from 2040 to 2020, 2025. And, he raised his hand. He was sitting at the back, and he said, what does that mean? You're talking about improving a line of vision or 2 lines of vision. What does that mean? So this slide is designed not for the people here in person, but if you're at home and you have a standard size monitor right now, if you're able to move 20 feet back, about 20 feet back from where you are, try reading these lines, with or without your glasses or contacts. You can do that for contrast. But that will give you an idea of basically what kind of acuity is required for each of these levels. 20/20 is what everyone with a normal, healthy eye and a decent pair of glasses should be able to see. 20/15 is supranormal. So that means you're able to see at 20 feet what a normal adult needs to go up to 15 feet to see, okay? Many children will have this. Many children will have 20/15, and they'll usually lose it in their 20s or 30s. But anyway, this gives you some idea. Of course, someone who's 2200, they just see the big E on the eye chart. They can't see anything below that, and that's the threshold for legal blindness, okay? All right. This slide, I'm not going to go through entirely. This is really more for the trainees if they ever want to go back through these slides. But it is a flow chart demonstrating some of the pathologic and pathophysiologic changes that occur in diabetes mellitus that drive, in particular, diabetic macular edema. Okay, and what I'd like to point out is there are a number of factors, soluble factors mostly, but other factors that drive this process. So one key one is VEGF. Vascular endothelial growth factor is profoundly upregulated in the diabetic eye, especially diabetics with diabetic retinopathy, I should say, profoundly upregulated. Take a look at a couple of other factors, IL-6 and TNF-alpha. So two of the principal pro-inflammatory cytokines. Look here as well, the adhesion molecules, intercellular adhesion molecules, lectins, integrins. So there's leukostasis within the vasculature of the diabetic retina. Okay, so really there's a combination of low-grade chronic inflammation as well as increased VEGF, and that leads to vascular incompetence, and that's how these patients get macular edema. Eventually, unfortunately, this will lead to a loss of endothelial cells. Pericytes, loss of pericytes is a very early change, which I'm sure the audience knows a lot about. It happens in the retina as well. But when there's loss of endothelial cells, significant loss, that's particularly bad, because then there's chronic incompetence and our therapies don't work nearly as well. So we want to catch patients early, of course. Protein kinase C is also, interestingly, also heavily involved in diabetic retinopathy, although PKC inhibitors have not worked in clinical trials. We're not sure why. All right, so one of the learning objectives was review the treatments of diabetic macular edema. There are 3 treatments. The old treatment and the 2 newer treatments. So the first one is focal laser, and the other 2 are intraocular injections, okay, of 2 different agents. One is against VEGF, and the other, unsurprisingly, is corticosteroids, right? Because if you go back to this chart, you see all the various pro-inflammatory cytokines that are involved. Makes sense that those would be the 2 treatments, and they do work. Just briefly on focal laser, this has really fallen out of fashion. This used to be the only thing we could do for our patients. So here's a cartoon of the macula. It zooms in on the macula. You see microaneurysms. You might see some exudate or some edema on clinical exam. And we would literally just take our lasers hooked up to our slit lamps, and we would fire this low energy laser light focused on these microaneurysms. And honestly, it would work to some extent. It would prevent massive leakage from those microaneurysms for reasons we still don't completely understand, actually. Here's a clinical photo. So here's a patient with macular edema. You see the exudates very close to the fovea. That's the fovea there, the single most important part of the retina. And then there's multiple microaneurysms everywhere. And then this clinician has been extremely aggressive about their focal laser, okay? And these are scars from the laser about a year later. And unfortunately, these scars expand. And that's a major downside of focal laser because it is ultimately destroying a little bit of retina. So, of course, that also means that you can't treat right over the fovea, right? This is where we get our 20/20 vision from. So it was a major, major limitation of focal laser. And in the early treatment of diabetic retinopathy study in 1984, which was the single best clinical trial on diabetic retinopathy in the world at the time, it demonstrated that, yeah, laser works, but really only to stabilize vision. It rarely improved vision. So there was a 50% reduction in moderate vision loss with focal laser versus control. Very few patients improved vision. But now we're in a different age. So when I was here in 2017, I talked almost exclusively about the anti-VEGF revolution in retina care, which applies to diabetic retinopathy as well as to other diseases of the retina. And I'm not going to focus exclusively on it because we have other learning objectives today. But what is it? Well, you all know about vascular endothelial growth factor. And Bevacizumab was the first monoclonal antibody developed against VEGF. And it was originally designed for cancer, as you probably all know, colon cancer, breast CA. And it's actually not that effective in cancer. There's still some role for it, but it's really just an adjunctive treatment in certain cases. In ophthalmology, it's been a revelation. It really has been. So Bevacizumab, or Avastin, is a 140 kilodalton monoclonal antibody against VEGF. It is not FDA approved for the eye, okay? I'm obliged to say that. I will say that it is the single most commonly used drug for diabetic retinopathy because it's inexpensive, and I'll talk about that in a second, and it works. Repeated intravitreal injections of anti-VEGF will eventually cause improvements in edema in the vast majority of patients, 75% of patients or so. And we can consistently achieve a sort of 2 to 3 line of vision gain in most patients. And again, let me just go back to that eye chart. So that means we go from, say, someone who's 2100 to bringing them to 2050. And that can be a big difference. I know it doesn't sound like much. You're looking at the F and you're comparing it to the L, or you're looking at the P and you're comparing it to the smaller P. But in Kentucky, you have to be 20/60 in one eye to drive. So that can make a big difference in someone's life, especially if they live in a rural or suburban area. Makes a big difference where they don't have access to public transit. All right. There are other agents. So there are 2 other agents that are FDA approved, Ranibizumab and Aflibercept. They are both still on patent and they're much more expensive. Here's an example of a patient who comes in, diabetic, complaining of blurred vision in the left eye. Take a look at the OCT. They have macular edema. Okay, they get in there, that 20/60 vision. They get an injection of Bevacizumab. They come back the next month. Edema is a bit better, but they don't really notice any improvement. Get another injection. 20/50. Get another injection, and you can see the cystoid space is slowly getting smaller, and eventually they do notice the difference. They get to 20/30 and they notice there's a distinct difference in the vision. But it's taken time and effort on their part, and it's taken repeated invasive procedures. So that's the cost of this, or one of the costs, I should say. This is where I got asked that question about what does 20/60 versus 20/80 mean 3 years ago, because I presented a bunch of slides like this from clinical trials. The only point of this slide is this is from a seminal trial of ranibizumab given every single month, every 4 weeks to a patient in the same eye with diabetic macular edema. Okay, so every month they're getting this, and they wanted to see basically at 1 and 2 years how much did their vision improve. Well, if you give it to them every single month, yeah, the vision slowly gets better. 5 letters means 1 line, so you know. So 10 letters is 2 lines, 15 is 3 lines. And so, yes, there's usually a quick improvement in the first few months, and you can keep getting more, but boy, it takes a lot of effort. And some patients, if their curve is a little bit flatter, you know, they're discouraged by the treatment. And maybe some of you have heard that. I don't know. I wouldn't be surprised if you had. But on average, if patients stick with the program, they will improve. Okay. Now this chart is not a vision, but this graph rather is one of the change in the thickness of the central macula. So again, rapid change early on, and then you can still continue to get decreases in the thickness of the macula if you keep going. These units are microns. Again, 250 to 300 microns is normal thickness. These patients might have 500, 600, 700 micron maculas. Have any of you seen an intravitreal injection? I don't know why you would have. You have. Your grandmother, okay. Is that Simra? Our man in the background is one of our ophthalmology residents, intern right now. You've seen one. You didn't raise your hand. It's okay. Well, for those of you who haven't, I do this about literally 10 times a day. If I see 30 patients in a day, I will do this on 8 to 10 of them. And what we're doing is we're going through the pars plana. So that's part of the sclera that's exactly, it's basically 3.5 to 5 millimeters posterior to the limbus. The limbus is where the cornea meets the sclera. So that's a safe zone. We've got about 1 millimeter that's safe. And we can stick a needle right through that and inject something directly into the vitreous cavity. You go too far forward, you hit the lens. You go too far posterior, you go through the retina, and you cause retinal detachment. Probably sounds harder than it is. Once you've done it 20 times and we have calipers to mark the eye, it's not hard. But the first few times, yeah, it's a little nerve-wracking when you're a resident. Here's what we do. So we'll prep the eye. We've stopped draping the eyes, although they still do this in some places. In India, they do this on every patient. We'll anesthetize the eye with topical proparacaine or tetracaine. I'll take a Q-tip like this clinician and hold it up against the sclera for 30 seconds. We mark with calipers exactly 4 millimeters back. We place betadine before and after we've used the calipers, betadine 5%. That's iodine, I should say. Apologies for using the trade name. And then we go into the eye. And it's surprisingly well tolerated, I have to tell you. 95% of my patients tell me the thought of getting the needle is so much worse than the actual experience. So we're able to do a pretty good job. Here's a better idea of what it looks like in my clinic. All the patients are wearing masks these days. We're wearing masks and gloves. These are calipers not calipers, specula that hold the eyelids open so that if they blink with one eye, the operative eye remains open, and then we do the injection. I wouldn't have specula on both eyes at the same time. That's very uncomfortable, but we'll do 2 eyes on the same day sometimes. Briefly, a quick comparison between the anti-VEGF agents. They have different systemic safety profiles, though they're all safe, I have to say. They all are relatively efficacious, although Ranibizumab and Aflibercept, the on-patent ones that are FDA approved, are a little bit better, and I'll show you some data on that. But take a look at this. This is the line where they're really dramatically different. And that's why Bevacizumab, and again, we're using it off-label. It's not FDA approved, but it's the very first monoclonal antibody against VEGF, and it works in the eye, and it's much cheaper. This is probably closer to $50 now. Eventually, NEI, National Eye Institute, did a head-to-head randomized comparative effectiveness trial into 3 drugs, which is what, as clinicians, all of us want. We don't just want the pharma trials where they hawk their own drug and compare it to placebo, compare it to an old treatment. And what we found is that, yes, again, they're getting injections every month, okay? And red is Bevacizumab, the light blue is Ranibizumab, and the dark blue is the latest drug, Aflibercept, and they all work. All patients improve, but there is a difference. And Bevacizumab was inferior to Ranibizumab and Aflibercept, although over time they can still catch up. All right, so let's talk about corticosteroids for diabetic macular edema. So the intravitreal steroids, there's 2 of them principally, triamcinolone and dexamethasone, have similar efficacy to anti-VEGF. They have one main advantage, which is that in patients who are non-responders, I mentioned about 70 to 75% of patients respond to anti-VEGF. These generally will work to some extent in the 25 to 30% of non-responders. That's the main advantage, but it has significant drawbacks. Increased risk of glaucoma, accelerated cataract. And they don't modify the disease course of diabetic retinopathy the way anti-VEGF does. And I'll talk about what I mean about that when we talk about proliferative diabetic retinopathy. Here's my point about a minority of DME patients who don't respond to anti-VEGF, that 25 to 30% will respond. And then the other advantage is that we have DME, we have these steroid agents that are longer acting. So there's a dexamethasone intravitreal implant that lasts about 3 months in the eye. It's supposed to elute drugs steadily with zero-order kinetics for about 6 months. It works for about 3 months. There's now a new one, a fluorescein implant, again injectable in the clinic, that lasts for 3 years. But it's expensive. It costs $8,000. So that's something to bear in mind. And, of course, the risk of glaucoma. And that's really the one we worry about more so than cataract, because cataracts are so easy to surgically remove. It's a very safe and effective procedure. Here's what the dexamethasone implant looks like. The implant is right on the tip here, and we have to inject it into the eye and then depress this plunger. Here's what we do in clinic. It's slightly more involved in the anti-VEGF injections. You'll notice that I'm holding calipers here, or rather the clinician is holding calipers here in one hand, and then in the dominant hand applying this injection, which is pretty large. It's about 22 gauge. So we usually use 30 gauge or 32 gauge, which is much less painful. So this is it's more painful. There's a little bit of risk that the wound will leak, but generally still pretty well tolerated. This is my treatment algorithm for 90+% of my patients with diabetic macular edema. We won't go through it step by step. It's really here for reference. But the broad strokes are that I will start with Bevacizumab. If that doesn't work, after trying it several times, I'll move on to Aflibercept, which, as you saw in those clinical trials, the comparative effectiveness ones, is the drug that has probably the best efficacy. I'll add laser only in rare cases, and then if I'm in that group of patients, the quarter of patients who are non-responders, then I'll add steroid or even combine steroid with Aflibercept. There are some patients who will respond to vitrectomy surgery, but that's really a last resort for diabetic macular edema. Won't be talking about that today. Okay, so let's shift gears entirely and stop talking about a structural complication, diabetic macular edema, and let's talk instead about the advanced form of diabetic retinopathy, proliferative diabetic retinopathy. So this is a form that will cause blindness if it goes untreated, okay? So retinal ischemia is the problem that drives everything, really, or just about everything in diabetic retinopathy. And that drives an upregulation in VEGF expression, and this causes capillary leakage, so diabetic macular edema, but also neovascularization. Now, since the diabetic retinopathy study in the 1970s, this was really the first big randomized controlled trial on diabetic retinopathy, there has been one proven treatment that was established by this trial, and that's Panretinal Photocoagulation, or PRP. It means laser to the peripheral retina. Here's some examples of neovascularization. So the thing that you can't appreciate, I'm sure you can see how these are all close to linear, or only slightly curvilinear, whereas you've got a whole big frond that's almost turning in on itself. What you can't appreciate from this two-dimensional photo is that these are growing into the vitreous. So these are coming out towards me when I examine them in the clinic. And that's why when they bleed, they can spill into the vitreous, unlike regular blood vessels. And then here's the picture I showed you earlier with massive neovascularization of the disc. We will still sometimes perform old-fashioned fluorescein angiogram, where we put in an IV for about a minute, inject fluorescein, it travels through the systemic circulation to the eyes, and then we see it flow through the retinal vasculature. Here's an example of a normal fluorescein angiogram in the early phase. Here's a highly abnormal one. These are microaneurysms that light up, these little dots. And then these ones with the massive leakage, that's neovascularization. So the FA is still helpful for us because it will sometimes pick up NV that we can't see clinically with our clinical exam. What does panretinal photocoagulation look like and feel like for the patient? Well, there's two ways of doing it. We can either put the patient at the slit lamp, put a contact lens over their eye and start that way. That's how we always used to do it. Or we can actually lean the patient back and we can attach a laser to our indirect ophthalmoscope and laser them like this. So either way works. If patients are real blinkers and it's going to be hard for them to wear a contact, I'll do this method on the right. I think it works very well. And then what does it look like on the retina? Well, this is what it looks like. The moment I'm done doing PRP, you will see these yellow-white burns in the peripheral retina. And you see we, of course, very deliberately spare the macula. All right, we don't want to damage the macula. But we are placing burns in the peripheral retina. And here's a wider field fundus photograph where you can see this is now about 3 months after PRP. You can see this patient has fairly dense scarring of the peripheral retina, and that's all the effects of the laser. Well, what are the cons of PRP? Well, this is a patient here. This is another wide field fundus image. This is a patient with an inherited retinal degeneration, retinitis pigmentosa. And now compare it to this patient who has proliferative diabetic retinopathy status plus PRP. They look pretty similar, don't they? And they look that way because laser is fundamentally a destructive procedure. What we're doing is we are killing the peripheral retina so that dead retina no longer expresses VEGF. Ischemic retina is bad because it doesn't see, number one, and it expresses VEGF, which will destroy the eye. So what do? We do something pretty primitive and barbaric. We destroy the peripheral retina as best we can. We try to leave some because there's a lot of redundancy in the retina. So it's not as though these patients have no peripheral vision. They still have some, but it's lower sensitivity. If we really have to keep lasering because they don't respond, so for instance, look in this area, very dense scarring, this patient will not have vision corresponding to this portion of the retina. So this is the nasal retina, so in towards the nose. Nasal retina sees the temporal world, so this patient's going to have a blind spot temporally. And unfortunately, it's something we have to accept to save the eye. Although there is another way, which we'll get into in a second. So the fundamental problem, as I said is it's retinodestructive, so there is decreased peripheral vision to some extent. There's definitely decreased color vision and contrast sensitivity. But, and this is the main advantage, you can do one PRP and this patient can be set for life. Even if they start getting A1Cs of 10, 11, 12, they may not break through if you do one good laser, like the laser here on the right. Okay, if you can do that in one sitting or maybe two sittings, they can be one and done or two and done. They can still break through occasionally. They get A1Cs that are really high if they have a genetic predisposition, family history. But generally, we can get someone to the point where they are done. They might get macular edema, but they're not going to lose the eye. They're not going to go blind. Compare that to the alternative. So this is what's arisen in the last few years. We use anti-VEGF for diabetic macular edema, but VEGF also drives neovascularization. So can you use anti-VEGF injections to treat PDR? Absolutely you can. Without a doubt you can. You can cause regression of neovascularization with anti-VEGF. I'm going to speed up a little bit so we have time for our last section. So there are many pros to this. If someone has a dense vitreous hemorrhage, we can't do laser, but we can inject and we can start to get that NV to regress. If the patient has diabetic macular edema, this will also treat their macular edema. And of course, most important of all, we're not destroying retina. So whenever it regresses, they're still going to have that normal color vision and peripheral vision. Cons, you need a lot of injections, especially in the first year. By no means is this one and done. In fact, it might be the exact opposite, and I'll show you some evidence about that in a second. Injections may need to continue indefinitely, and which really I think is a major downside. And then here's one that's perhaps even bigger. Patients who are non-compliant and who present after some delay in treatment for whatever reason can come back with severe neovascular complications, okay? Here is a table from a study done at the University of Michigan on patients who were under this regimen of anti-VEGF injections for PDR and then had some interruption in treatment. They had 13 patients, okay? And when these patients came back, and on average they came back a year later, they were away for a year, 70% of them had vitreous hemorrhage, 38% of them had neovascular glaucoma, 31% had tractional retinal detachments. And these two are extremely serious. I mean, these patients may just go blind no matter what you do once you see them. And here are the reasons why. Take a look at this. Intercurrent illness, non-compliant financial issues. Do those sound familiar to people in the audience? I mean, those affect almost all our patients, particularly diabetics because of their multiple comorbidities. So this gives me major pause. There was a trial, again done by the NEI, of PRP versus anti-VEGF injections for the management of proliferative diabetic retinopathy. And basically, patients were randomized to one or the other. They got PRP to start, 1 or 2 sessions, or they got Ranibizumab to start. Here's the number of injections that they needed each year over 5 years. Now, note that the PRP group also still occasionally got injections for diabetic macular edema. Okay, that's why the number is in 000 here. 7 injections in the first year. 3 in the second year. Okay, getting better. But it doesn't get better after that. Patients have to keep coming back indefinitely. And again, if they get sick and they miss a few appointments, they could come back with a real problem. So major trade-offs. I will be honest, I do not favor this approach, especially with the patient population I have, which I know I share with many of you. So I don't like this. I still do a lot of laser, but occasionally there's the right patient who shows up every 4 weeks, and I will do this. All right, the last portion of our talk, which is significantly shorter, so I think we will have time. What are the unmet needs in diabetic retinopathy? Well, I've identified 3 primarily. One is the need to reduce treatment burden. So take these diabetic macular edema patients. Some of them continue to need injections every month or every 2 months for years. That's hard. That's extremely hard. We need better agents, longer-acting agents. We need a way to revascularize the retina. So I showed you some pictures of ischemic retina, and we can't reverse ischemia. We need a way to reverse it. We need a way to revascularize the retina the same way diabetics can get CABGs or coronary stents for coronary artery disease. We don't have that, beyond our capability at the moment. And one that I think you guys all know all about, we need to screen diabetics. We need to screen more of them more efficiently, and it's a big problem, even in a wealthy country like the United States. All right, so treatment burn, the problem. A large minority of our patients require Q4-week injections indefinitely. Or you can replace 4-week with 6-week or 7-week, but it's still a lot. It's still a lot. What's the solution? Well, we need longer-acting delivery of anti-VEGF. And there's multiple ways to do this, okay? So here are the principal ones being investigated right now, which are entering later stage trials. So one is, there's now a surgically implantable port. It's not FDA approved yet. It's entering phase 3 trials. But what we do is we make a sclerotomy, a couple of millimeters. We insert this reservoir and suture it to the globe, suture it to the sclera. And then we inject the medication. In this case, it's Ranibizumab with the company that's producing this. But it could be Aflibercept or Bevacizumab. And it will slowly release the drug into the eye over about a year. And then when it runs out, you can refill it. It's a nice idea. The problem is that you have indwelling hardware in the eye. And so the conjunctiva, the proverbial skin of the eye, can erode over this area. And that increases the risk of infection, potentially devastating infection, endophthalmitis. So in the trials, the endophthalmitis rates were 3%, which for me is unacceptable. But hopefully this will improve. Nanoparticles, I think it's a very exciting area. Nanoparticles and microparticles that are laden with anti-VEGF drug. So you can inject it just like a regular intravitreal injection, and then it will slowly release the drug, release the antibody into the eye. A lot of these use PLGA, polylactic coglycolic acid, which is appears to be safe in the eye. And let's see, again, these are in phase 2 and phase 3 trials, but I think this could be promising. Gene therapy for diabetic retinopathy, not for a genetic disease, but for an acquired disease. One where we use a non-immunogenic vector like AAVs, so that's adeno-associated vector, to encode a gene that will produce a gene product that is an anti-VEGF antibody. And so this is well underway, and I think it's a very good idea for diabetic retinopathy, where there's yet to be shown to be a downside to anti-VEGF. It seems like VEGF's not everything, but it seems like the more anti-VEGF, the better. And then finally, of course, I mean, can't we go after other targets? Yes, of course we can. One that is now entering phase 3 trials is looking at Ang2. So angiopoietin-2 is a ligand for the Tie2 receptor. It's a tyrosine kinase. And when Ang2 binds to Tie2, it causes both capillary leakage as well as, or I should say, it makes the blood vessels more sensitive to VEGF. So then the effects of VEGF are potentiated. So now there's this dually targeted monoclonal antibody against both Ang2 on the one side and VEGF on the other side. And I think all of these have advantages and disadvantages, but I think the future is bright in this regard. Revascularization of the ischemic retina. Ischemic retina doesn't see, and it pumps out VEGF. It's a double hit. Here's a normal fluorescein angiogram. This sort of blush of this hue of color that you're seeing, of lighter color, is perfusion. And here you can see that this is normal. This is called a foveal avascular zone. But here you can see that foveal avascular zone is dramatically enlarged, and there are other areas of black spots. These ones are actually scars from PRP, but these other black areas are just lack of perfusion, capillary non-perfusion. This is the one where we're probably the farthest away from doing anything about, sadly. There are approaches under investigation. I'm excited about both of them, but the second more than the first. The first is infusions of endothelial progenitor cells. So I don't know how much you guys have heard about this, but this has been tried for peripheral arterial disease, which of course our diabetic patients unfortunately get. with very mixed results. So there is a form of a, it's not multipotent, but it is a stem cell-like cell that goes to the vasculature, comes from the bone marrow, that just produces precursors to the endothelium, to vascular cells, endothelial progenitor cells. Hasn't really mixed results in peripheral arterial disease. Some people are just starting to work on it in diabetic retinopathy. It's still preclinical. There hasn't been a good trial yet of it. Another approach, which I'm excited about, is activating the Wnt-Frizzled pathway. So Wnt is very important in normal vascular development in the eye. Not so much in other parts of the body, but in the eye very much so. So now there's a protein that's been developed which is basically an agonist in this Wnt-Frizzled pathway. And it's just entering phase 1-2 trials. We may be starting it here at UofL as well. Be interesting to see if it works. I really hope it does. Last problem, and we're almost done here, screening. So you all know this problem. You know it better than I do because I'm seeing patients in clinic. I will do screenings, but I'm not doing remote screenings out in the community. There's a lot of diabetics to screen. There aren't that many ophthalmologists. We tend to be clustered in cities like here in Louisville. And of course, I mean, copays and insurance are a problem. Copays to specialists are often very high, $40, $50, depending on the insurance plan. And I think most people in the community agree that telehealth is a good solution. It's maybe not the only solution, but I think it's a very good, increasingly a good solution. And there's a couple of ways to do this. So there's the old approach, which is a traditional telehealth approach, and now there's more modern approaches using artificial intelligence. So we have non-mydriatic fundus cameras now in primary care offices, mostly at Cardinal Station, where the Department of Family Medicine is, also with internal medicine. Is endocrinology using any of these? No. Yeah, and that's been the focus, because of course we want to get to people early. But they're non-mydriatic, which means you don't have to place the eye drops, the dilating drops in. They'll take a photograph. They're not going to get the whole retina, right, because the pupil's not dilated. But they'll get this sort of area. They'll get the macula, the posterior pole. And then under the old rubric, the old paradigm, these photos would be taken. They'd be sent to one of my colleagues at the eye center. Her name's Dr. Wong. She'll review them, and she'll give you some grading, 1 to 2 weeks later, saying, everything looks good, or, oh, there's a problem, please refer. There's actually now the very first FDA-approved artificial intelligence program or device. So it does the same thing with the same kinds of cameras, but then instantaneously you get back a grading of mild diabetic retinopathy or less, or greater than mild diabetic retinopathy, please refer. And I left out the name of it just because I'm not trying to obviously advocate for any commercial entity. It was developed at the University of Iowa. But it's a first. It's a first for all of the FDA, the first AI-approved or FDA-approved AI device. And it certainly has advantages because you just cut down on that extra step of waiting a week or two, having to call the patient, send a letter to the patient. I think cutting down on every step is helpful. And I'm hopeful that as the price of these technologies decline, they become more user-friendly, they're cheaper, we have better AI systems, that we are going to have a good way forward with screening, and we're going to be able to do a much better job, particularly for our indigent patients and patients who live in rural areas. So to conclude, we've got a few minutes left. Anti-VEGF has revolutionized the treatment of DME. We can improve vision rather than just hoping to stabilize it. Anti-VEGF is a reasonable alternative or adjunct to PRP for active proliferative diabetic retinopathy. But increases in treatment burden and non-compliance with this regimen can lead to severe complications, which really do scare me. And finally, reducing treatment burden, revascularizing the retina, and improving screening are major unmet needs in diabetic retinopathy. Thank you very much. And I'll take questions. Oh, so let me stop sharing. So there, yes. So the question from Dr. Mokshagundam was: is there a difference in type 1 and type 2 diabetics? The The simple answer is, in the cardinal manifestations, really all the manifestations of the disease, no. But in the pace of the disease, yes, quite dramatically. In fact, patients who have gastroparesis, patients with advanced kidney disease and type 1 diabetes, they seem to get much more rapid development of PDR. And once the PDR sets in, it can continue to escalate much more rapidly, particularly in those patients with severe complications of diabetes elsewhere in the body. And that's scary. I mean, those are patients where you need to get the laser going immediately. You need to see them the next week after that, the next week after that, until you've got sufficient laser or anti-VEGF in. As opposed to type 2 diabetics, where some of them are very severe and there is a range, but you rarely see that kind of rapidity to the disease. So it's very concerning. I mean, it's scary when you see patients like that. But again, they can all be treated. As long as they don't come in too late, we can usually take care of just about all of them. Other questions? Anyone at home? I think you can just unmute and speak up, or you can type.
I have one. Steve Winter's here. Nice to see you. Thanks for giving the lecture.
Nice to see you again. Thank you very much.
Anyway, my question is about vitamin D deficiency, and there's a literature connecting vitamin D deficiency and proliferative retinopathy. What's your take on all of that?
Yes. Thanks for the question. Yeah, I think it's very intriguing. I think it's plausible. I think it's a pathophysiologically plausible link. I won't get into the details. I don't know them that well, but with the pleiotropic effects of vitamin D, it's very plausible. And you saw all the different factors involved in the pathophysiology of both PDR and DME. So I think it's biologically plausible. I think there's epidemiologic evidence that supports it. And what we don't have, of course, and the thing that all retina specialists want is a randomized controlled trial of supplementation. It's hard to do, of course. You have to raise levels to a certain extent and then follow people long term. But actually, the Diabetic Retinopathy Clinical Research Network, which is the NEI's study group for doing clinical trials in diabetic retinopathy, which has been hugely successful. They did a number of these trials that I referenced in the talk. It's been raised to try to put something together like that. It's not a high priority, but I'm optimistic that sometime in the next 3 to 5 years, we may actually have a trial that we will attempt. So thank you for raising that point. Of course, not enough time today to talk about all the many fascinating connections and pathophysiology, but yes, I think there could be a very real connection. Underappreciated and under-discussed amongst retina specialists. So thank you for bringing it up.
Yes, can I ask a question?
Yes, please.
Okay, Dr. Sandhu, nice talk and nice review of the whole DR situation. You mentioned about A1C, 10, 11, 12 being in the range that are that's when you see these retinopathies. When is the earliest it starts, and can the improvement in the A1C reflect an improvement in the retinopathy?
Absolutely. So I didn't include that sort of data, which is gold standard data from the UK PDS and the DCCT, but the lower the better. And I mentioned particularly high A1Cs for when it can break through laser treatment. But we will see patients with significant levels of diabetic retinopathy at 8.0 or more. For type 1 diabetics, who of course they're diagnosed really pretty much at the time when they develop the disease, we typically will not see any diabetic retinopathy for 5 years. Now, some patients are not well controlled, of course, but some of them are. Many of the type 1 diabetics are. So it can be variable still, that 5-year number. But generally speaking, I don't have a number I can give you, unfortunately. But if someone maintains an A1C of 7.0 or less, I know the guidelines on that have changed, particularly for older patients, about risks and benefits of where the A1C should be. But there's no doubt for retinopathy, the lower the better. 7.0 or under, the risk is low of ever getting PDR.
Okay, thank you.
You're welcome.
I have a question.
Yes, hello.
Hi. So I guess my question is, do you see any racial, excellent talk, by the way, it was great. Do you see any racial variations in the presentation to, as well as the response to therapy?
Yeah, great and very interesting question, as all the questions have been. The short answer is no. We think that all of the differences that we see by race are basically accounted for by other covariates, other comorbidities in A1C. So for patients presenting with, same level of blood pressure control, same level of blood glucose control, same age, same comorbidities, but say Hispanic versus African American versus white, we don't think there are significant differences between the disease.
Is there any relationship between response to anti-VEGF treatment and VEGF?
Yeah. So the question was, did you say in the retina or in the serum, or both? Yeah, sure. So another question from Dr. Mokshagundam. It was, is there a relationship between response to treatment, anti-VEGF treatment, and anti-VEGF levels in the eye and serum? So the serum, the relationship is weak, as you probably expect. The relationship in the eye, very strong. The higher the VEGF levels in the vitreous, the better the response to VEGF treatment. Now, the vitreous is the only part of the eye that in vivo we can really, that in the aqueous, that we can safely access by tapping the eye. We can't get a chorioretinal biopsy. That's a very dangerous thing to do. We have to do that in the OR. So we don't have the exact VEGF levels in, say, the retina per se, but we know that it's going to be similar, the concentrations. And yes, very tight correlation. And actually, there's a disease, an eye disease, that has even higher intravitreal levels of VEGF, which is called retinal vein occlusion. May have heard of it. Central retinal vein occlusion or branch retinal vein occlusion. Diabetics are unfortunately at higher risk of it. Surprise, surprise, getting that as well on top of their diabetic retinopathy. And they have the highest VEGF levels on average, and they have on average the best response to a single injection of anti-VEGF. So yes, very tight relationship.
The flattening of the response because the VEGF.
So like over time, is there a loss? Interestingly, there isn't really. Someone who responds to their first 3 injections tends to continue to respond as long as their systemic parameters are the same. You would think it does seem a little counterintuitive. I mean, you make an excellent point. It seems a little counterintuitive because, yeah, the VEGF levels are not going to be nearly as high. But I think the reason for that is eventually we'll go to a PRN treatment regimen. And so patients will remain what we call dry, no fluid, no edema. And then eventually they'll get fluid. And once that recurs, the VEGF levels have gone up significantly. So I think at the time that we're injecting on our PRN regimens, actually the VEGF is again fairly high. Any other questions? All right, well, thank you. And let me just say that the Department of Ophthalmology is going to switch to EPIC in March. So whatever problems, which I believe your service is also doing. Yeah. So all the problems that I know your division has had with sometimes getting our notes, and I'm so sorry about it, will be solved for good. All right. Thank you very much, everyone. Do I just X out?